Glomerulonephritis occurs when there is inflammation and damage of the glomerulus, usually due to immunological attack. Signs and symptoms differ according to the type of syndrome and whether they are acute or chronic. The diagnosis follows an algorithm in which we should identify the syndrome, nephritic versus nephrotic. We check the complement and complete the diagnosis with the specific information. However, sometimes there is no option but taking a biopsy. Treatment. Many glomerulonephritis benefit from treatment with corticosteroids and immunosuppressive therapies, but some of them can have different therapies, for example plasmapheresis or kidney transplant. Etiology. Etiology includes primary and secondary causes. There are 7 primary causes of primary glomerulonephritis and many secondary causes, but we will focus on these ones. Primary causes include minimal change disease, post-streptococcal glomerulonephritis, mesangial IgA glomerulonephritis, rapidly progressive glomerulonephritis, membranoproliferative glomerulonephritis, focal segmental glomerulosclerosis, membranous glomerulonephritis. Secondary causes include Henox-Schönlein purpura, systemic lupus erythematosus, sepsis, systemic vasculitis, subacute endocarditis, shunt nephritis, and cryoglobulinemia. Signs and symptoms in an acute setting differentiate nephrotic and nephritic syndrome. Nephrotic syndrome is characterized by a damage of the glomerular basement membrane, which in turn filters out many proteins. In nephrotic syndrome, we can see proteinuria more than 40 milligrams per meter square per hour in children. There is also presence of hypoproteinemia and hypoalbuminemia, which cause a decrease intravascular volume and renin-angiotensin-aldosterone system activation. Overall, the net result is the appearance of edemas. Very typical is the appearance of periorbital edemas. There are also increased incidence of infections due to the loss of immunoglobulins in urine, especially infections by encapsulated bacteria. Another thing that can happen is the appearance of thrombosis due to the loss of anticoagulant proteins. There is also decreased transport proteins and decrease in iron, copper, zinc, and thyroid hormones. The only thing that increases is the synthesis of lipoproteins as a compensatory mechanism of the liver, so hyperlipidemia and hypercholesterolemia develop in nephrotic syndrome. On the other hand, nephritic syndrome manifests with proteinuria out of nephrotic range, hematuria, uremia, which can develop in acute renal failure if more than 1.2, and there is the development of hypertension. There can also be edema, again due to renin-angiotensin-aldosterone system activation and retention of sodium and water. Sometimes there is an impure nephrotic syndrome, like in focal segmental glomerulosclerosis, which is nephrotic syndrome with hematuria. In order to say that this is nephritic syndrome, we have to find 2 out of the following 3: hematuria, acute renal failure, and/or hypertension. There can also be edema in nephritic syndrome for the previously explained RAS activation. In a chronic scenario, we can speak about chronic renal insufficiency and developing chronic kidney disease. This is renal damage for more than 3 months. The staging is according to glomerular filtration rate. We can say that moderate stages show up a rise in serum creatinine as well as polyuria, nicturia, and anemia. Severe chronic kidney disease causes a rise of H+, developing metabolic acidosis with increased anion gap and also rise of potassium, phosphate, and calcium ions. In this stage, there is unspecific uremic symptoms such as anorexia, nausea, and vomits. Terminal or end-stage renal disease shows up an increase in serum sodium and water, Specific uremic symptoms such as encephalopathy, cardiomyopathy, or renal osteodystrophy can develop in this stage. It is at this point in which we think about renal replacement therapies like hemodialysis or kidney transplant. In the following slide, we can classify primary glomerulonephritis in acute or chronic. We can see that acute glomerulonephritis include minimal change disease, post-streptococcal glomerulonephritis, mesangial IgA nephropathy, rapidly progressive glomerulonephritis, and membranoproliferative glomerulonephritis. Chronic can be membranoproliferative glomerulonephritis, focal segmental glomerulosclerosis, and membranous glomerulonephritis. Now we're going to speak about each individual cause. Minimal change disease. It is the most frequent cause of nephrotic syndrome in children for more than 80% of the cases of nephrotic syndrome. The cause is usually idiopathic. Minimal change disease is more frequent in boys than girls, and the mean age of presentation is between 3 and 4 years old. 80% of the children are under 6 years old. The pathophysiology includes increased cytokines in glomeruli and damage to podocytes. It manifests as a pure nephrotic syndrome with selective proteinuria. The prognosis is usually good. 50% recover spontaneously and 90% respond to corticosteroids. Those who don't recover can progress to focal segmental glomerulosclerosis. Corticosteroids are given for 4 weeks and during alternate dates for another 4 weeks. 50% relapse at least one more time. But if the relapses are multiple, immunosuppressants like cyclophosphamide, tacrolimus, mycophenolate, or rituximab can be added. In children, the frequency of the relapses decreases with age. Sometimes there can be low levels of immunoglobulin G, existing tendency to infections. How about post-streptococcal glomerulonephritis? It is the most frequent cause of nephritic syndrome in children. The peak incidence is at 7 years of age. It arises from previous infections with Streptococcus pyogenes, formation of circulating immune complexes which deposit in glomeruli. The hematuria never shows up at the time of infection. The infections can be cutaneous infections like impetigo, erysipelas, or cellulitis with a 2-3 week incubation period, pharyngoamygdalitis with a 1 or 2 week incubation period, or reinfection, more than 5 days incubation period. It can cause acute renal failure. The treatment consists on treating the strep infection as a prophylaxis. If the nephrotic syndrome develops, symptomatic therapy treating hypertension must be given, with diuretics and antihypertensives. If conservative therapy fails, dialysis is indicated. About mesangial immunoglobulin A glomerulonephritis, it is the most frequent glomerulonephritis in Mediterranean area. Immunoglobulin A nephropathy is uncommon in children younger than 10 years. In fact, 80% of patients are between the ages of 16 to 35 years at the time of renal biopsy, so it is more a disease for young adults. The causes include Henoch-Schönlein purpura, which is IgA vasculitis, or liver disease because it increases the circulating IgA. Henoch-Schönlein purpura, or HSP, is a condition where blood vessels become inflamed, irritated, and swollen. HSP usually affects the small vessels in the skin, causing a rash that is called purpura. It can also affect blood vessels in the intestines and the kidneys. Mesangial IgA glomerulonephritis courses with recurrent hematuria, sometimes nephritic syndrome. Generally, it occurs at the same time as an episode of upper respiratory tract infection like a flu. For the diagnosis, we should know that 50% of patients have increased circulating IgA in serum. The prognosis is good. The treatment consists in controlling hypertension with diuretics, ACE inhibitors, angiotensin receptor blockers, and calcium channel blockers. Corticosteroids can lower the recurrences and also the proteinuria. Rapidly progressive glomerulonephritis is pretty self-explanatory. It manifests as nephritic syndrome, which progresses to acute renal failure in days or weeks. It can cause pyuria due to tubular destruction. There are three types. First one is good pastor syndrome. In here we can find antiglomerular basement membrane antibodies. Lungs and kidneys are involved. It is an extremely rare cause of rapidly progressing glomerulonephritis and chronic kidney disease in children. It is associated with acute pulmonary hemorrhage and it has a poor prognosis. Second type is immune complexes. It has decreased complement and subendothelial immune complexes formation. It is caused by any glomerulonephritis with a lot of inflammation, except minimal change disease, or post-infection after infective endocarditis or sepsis. Interestingly, shunt nephritis, a secondary cause of glomerulonephritis, manifests as this type. Shunt nephritis is an immune complex-mediated glomerular disease associated with chronically infected ventriculojugular shunts for hydrocephalus. It develops as rapidly progressing glomerulonephritis type 2. Systemic diseases can also result in rapidly progressive glomerulonephritis type 2, like systemic lupus erythematosus or neoplasms. Type 3 is pouchy immune. It is ANCA-associated. It is caused by small vessel vasculitis like granulomatosis with polyangiitis, microscopic polyangiitis, or eosinophilic granulomatosis. The treatment of rapidly progressive glomerulonephritis consists on corticosteroids and cyclophosphamide, although type 1 can benefit from plasmapheresis. Up to 50% of the patients affected by this disease need dialysis in 6 months. Due to its bad prognosis, it is recommended to perform a renal biopsy when this clinical picture is suspected. Membranoproliferative glomerulonephritis can have a nephritic or nephrotic course. The causes include hematological tumors, infections like hepatitis C virus or visceral abscess, infective endocarditis, malaria or schistosomiasis, or autoimmune, like systemic lupus erythematosus, rheumatoid arthritis, or cryoglobulinemia. There are three histological types. Diagnosis is usually by renal biopsy. Treatment consists in identifying and treating the underlying cause, and treat the predominant syndrome. Nephrotic syndrome can benefit from ACE inhibitors and angiotensin receptor blockers, and nephritic syndrome can benefit from corticosteroids and immunosuppressants. Sometimes renal transplant is required. Focal segmental glomerulosclerosis is not a single disease, but a pattern of kidney damage. It is one of the most common causes of nephrotic syndrome, especially in children and adolescents. If it is of immune cause, it is called focal and segmental sclerosing glomerulonephritis. It can also be idiopathic or appear over another glomerulonephritis, like minimal change disease or mesangial IgA glomerulonephritis. It causes an impure nephrotic syndrome, with non-selective proteinuria progressing to chronic renal insufficiency. The causes include diseases that are causing hyperfiltration, like vesicoureteral reflux, chronic tubulointerstitial nephropathies, and as well IV heroin use, HIV, Alport syndrome, systemic lupus erythematosus, neoplasias, radiation nephritis, and some others. The treatment is focused on treating the underlying cause, giving ACE inhibitors and ARBs, corticosteroids, plus minus immunosuppressants. Membranous glomerulonephritis is more frequent in adults. It's a rare histologic entity in children. Causes include idiopathic origin, secondary to solid tumors, secondary to infections, autoimmune, or adverse effects of drugs. It courses with impure nephrotic syndrome, so it means nephrotic syndrome with hematuria, and it has a chronic course. The diagnosis is made up with anti-PLA2A antibodies. It is highly specific. Treatment of the underlying cause and ACE inhibitors, ARBs, and if persistent, we can give immunosuppressants and corticosteroids. Systemic lupus erythematosus is a disease that can manifest in the adolescents. Lupus nephritis is more frequent and severe in pediatric patients with systemic lupus erythematosus and has been associated with higher morbidity and mortality rates. Lupus nephritis can cause 6 out of the 7 primary glomerulonephritis. We can classify these in those having a good prognosis and bad prognosis. The diagnosis is made checking the ANAs, and also decreased complement is shown up in serum. The treatment depends on the histological type and syndrome. It includes corticosteroids, immunosuppressants, and sometimes hydroxychloroquine, and ACE inhibitors and ARBs. Well, after going through each disease individually, let's see how do we do the diagnosis. For that, we will follow a diagnostic algorithm consisting in 3 steps. The first one is to identify whether it's a nephrotic or nephritic syndrome by urinalysis, serum biochemistry, blood pressure measurement, and physical exam. The second consists in checking the complement. Some diseases can cause hypocomplementemia. The third one is the specific features of each disease. Although this can be really helpful in helping us diagnosing, biopsy can guide us thanks to a specific histological pattern sometimes. Sometimes immunofluorescence is used to see the deposition of immunoglobulins in glomeruli. When to do a biopsy in a child is a very good question. Well, if it meets one of the following conditions. In a case in which we find an impure nephrotic syndrome, we have glomerulonephritis which doesn't respond to corticosteroids or relapse during therapy. There are more than 3 episodes of nephrotic syndrome per year. We have a nephritic syndrome other than post-infectious glomerulonephritis, post-streptococcal glomerulonephritis, with oliguria more than 3 weeks, decreased complement more than 8 weeks, or hematuria more than 6 months. In the next slide, we can find a classification of primary glomerulonephritis according to the type of syndrome. By this classification, we reduce the number of differential diagnoses to 4. Next should be identifying those diseases that course with hypocomplementemia. Here we can see a summary of those. So if we see the primary ones, it includes post-streptococcal glomerulonephritis, membranoproliferative glomerulonephritis, and rapidly progressive glomerulonephritis type 2. The secondary ones can be remembered with the mnemonic less complement, which are lupus, endocarditis, sepsis, shunt nephritis, and cryoglobulinemia. Lastly, let's focus on specific information which can help us guide us through the diagnostic processes. Sometimes we can see palpable purpuras in different types of diseases. The first one is cryoglobulinemia. In cryoglobulinemia, cryoglobulins typically precipitate, clump together at temperatures below the normal body temperature, which is 37 degrees. So in cold temperatures, the precipitate can clamp and can block blood vessels and cause toes and fingers to become gangrenous. It also causes membranoproliferative glomerulonephritis. Life-threatening complications of cryoglobulonemic disease require urgent plasmapheresis and/or plasma exchange in order to rapidly reduce the circulating levels of their cryoglobulins. We have also seen small vessel vasculitis as a type of rapidly progressing glomerulonephritis type 3. They can also occur with purpuras, and the same is for Genus-Holling purpura. Other information that we should take into consideration for diagnosis includes membrane minimal change disease accounts for 80% of nephrotic syndromes in children. Post-streptococcal glomerulonephritis courses with a previous streptococcal infection after an incubation period. Mesangial IgA glomerulonephritis has circulating immunoglobulin A in serum of 50% of patients. Rapidly progressive glomerulonephritis is characterized by acute renal failure in days or weeks. It can have antiglomerular basement membrane antibodies, which can be seen on the biopsy, and the presence of ANCAs in type 3, and there can be history of another glomerulonephritis with a lot of inflammation except minimal change disease. It can also be history of infection like infective endocarditis, sepsis, or shunt nephritis, or it can be secondary to systemic diseases like systemic lupus erythematosus or neoplasias. As for membranoproliferative glomerulonephritis, is related to hematological tumors, infections, and autoimmune processes. As for focal segmental glomerulosclerosis, it can be caused by hyperfiltration, HIV, IV heroin use, or other glomerulonephritis, or other tubulointerstitial nephritis. As for membranous glomerulonephritis, they display anti-PLA2A in serum. And that should be all. Please comment which topic would you like me to discuss next. Rate the video and subscribe for more. Thank you.